name's Tom Lloyd. I'm at Johns Hopkins, and I'm one of the directors of the Johns Hopkins Myositis Center, and I've been part of the medical advisory board at the TMA for almost 5 years now, and every year that I do this, I learn more from interacting with patients, and so it's really a great opportunity actually for us as advisors to hear from the patients, and we learn a lot from speaking with you all and answering your questions. So this is Myositis 101, and it's focused on inclusion body myositis. And so what I thought I would do is actually start with an overview of exactly what myositis is, and how is inclusion body myositis similar and different from other forms of myositis. How is inclusion body myositis diagnosed, and how is it managed? And then finally, a little bit about actual clinical trials and research. And there are other sessions later on in the meeting that are focused more on research and on actual specific forms of management like physical therapy and exercise. So this is meant to be a broad overview. I'm going to finish exactly at 5:15 since I know that actually need the room for something else. But if any of you have any questions afterwards, I'm happy to speak with you all one-on-one. All right, so let's get into it. What is myositis? So myo, the root word myo means muscle. Itis means inflammation. And so myositis is simply inflammation of muscle. Now, the actual medical term that you'll often hear is idiopathic inflammatory myopathy. And really all that means is muscle inflammation, and idiopathic meaning the actual cause is unknown. And that is true really of almost all forms of myositis. Myositis is comprised of a number of different diseases that all sort of fall under this umbrella that all have in common inflammation of the muscle. And often IBM is actually considered separately. And that's actually why we have a Myositis 101 for IBM, and down the hall there's one on all the other forms of myositis. And I'll explain the reasoning for that in a minute. So in most other forms of myositis, the actual muscle weakness is really caused by the inflammation itself, meaning the immune system, the inflammatory cells that are in the muscle are actually releasing factors that are causing the muscle to be weak. In IBM, on the other hand, it's actually a slow loss of muscle. So it's muscle atrophy that is the underlying driver of weakness rather than the underlying inflammation. Another distinction between IBM and other forms of myositis is in most other forms of myositis, there are a number of other organ systems involved. So the lung or skin and joints. In IBM, in the vast majority of times, the only actual organ system that's involved is skeletal muscle. So it won't affect the lung, the brain, the heart. However, your muscles that are involved in swallowing and breathing. The actual, what are called pharyngeal muscles that are involved in swallowing and diaphragm that's involved in breathing are sometimes involved. So that's why, in addition to actual muscle weakness, problems swallowing and sometimes later on problems with breathing can occur. Okay, so what is autoimmunity and inflammation? So I'll give you sort of a broad overview. So as you might be able to tell from the actual sound of my voice, I have a cold. I woke up actually yesterday morning, coughing, and actually right now I'm doped up on lots of different meds, so I'm not coughing and sneezing on you right now. So the way that happened was I was exposed to probably a virus, okay, and then and what happened was my immune system actually recognized this virus and actually revved up an inflammatory response against the virus. And the job of our immune system is to actually protect us from any foreign invaders, whether it's a bacteria, a virus, a fungus, bacteria, or parasite. And so what the immune system needs to do is recognize something as foreign, so it's not supposed to be there, whether it's a virus or a bacteria, and then it has to actually propagate a response. And what that means is there are lots of different cells of your immune system, cells known as T cells and B cells, macrophages, lots of different cells that are in our blood and circulate throughout our tissues, which are constantly looking for a foreign invader. And when they see that there's a response, they actually shut down that foreign invader and control the infection. And it's the inflammatory response that our immune system is doing to fight the infection that actually makes us feel sick. So us feeling sick is actually, in many cases, a good thing. Now, what happens in autoimmune disease is we think that an infection from, say, a virus or something else, or some other environmental trigger, and we don't really understand what those triggers are. It induces an inflammatory response, and whereas normally, if you don't get an autoimmune disease, the inflammation is controlled and goes back down, whereas if you have a genetic predisposition to actually developing an autoimmune response, what happens is your immune system actually attacks the own tissues of your body. And in a lot of cases, we think this is caused by molecular mimicry, meaning something on the virus is actually mimicking what is normally present in your cells, like in your muscle cells. And so, in general, in autoimmune disease, we think that the underlying cause is an environmental or infectious trigger of the immune system to actually recognize itself as foreign. Okay, and so another way of saying that is that there is a loss of tolerance, meaning as part of any infection or inflammation, the immune system has a way to regulate itself so that after it's cleared the virus, it tamps back down and stops fighting. So one way to think of autoimmunity is it's a persistent fight against some self-antigen. And the underlying cause really in most autoimmune diseases is really unknown. It's thought to be a combination of genetic factors as well as environmental triggers, perhaps viruses, perhaps exposures, perhaps the normal aging process. Now, oftentimes autoimmune diseases, including inclusion body myositis, are seen in more than one family member. And that's probably has something to do with the underlying genetics of the actual immune system. It's also why IBM and other forms of myositis are often present in the context of other autoimmune diseases, in particular rheumatoid arthritis and Sjogren's disease. So here's some examples of other autoimmune diseases. So I mentioned rheumatoid arthritis, which affects the joints. Actually, Sjogren's disease or syndrome affects your glands and usually causes dry eyes and mouth. And other autoimmune diseases, though, are typically not seen in IBM. For example, scleroderma often affects the skin, similar to dermatomyositis. Multiple sclerosis is an autoimmune disease that affects the nervous system. And myositis broadly is an autoimmune disease affecting the muscle. Okay, so it's really the inflammation in the muscle that actually gives it its name. So here's what it looks like under the microscope. So everything here in pink or red is normal muscle. So this is a single large muscle cell. And all this in here are inflammatory cells. So a muscle biopsy is often used to actually diagnose myositis. And one can really see the inflammatory response in many patients. Okay, so as many of you I'm sure are aware, there are a number of different forms of myositis. So there's inclusion body myositis, polymyositis, immune-mediated necrotizing myopathy, or IMNM, and dermatomyositis. These are the four most common ones that often people talk about, and there are other much more rare forms. Okay, so how's myositis diagnosed? The other than muscle biopsy, which I showed you, the other most important factor is having an examination, including a detailed history that is done by a physician who is experienced in myositis. So myositis is a rare disease. So if the doctor that you're seeing hasn't seen myositis before, it's possible that they won't be able to actually correctly diagnose the actual subtype of myositis, because the experience knowing what to look for in terms of the history and the examination findings are critical in diagnosing IBM and other forms of myositis. So while it's really the history, exam, and muscle biopsy that are critical to a diagnosis of IBM, there are a number of other lab tests that are often obtained that are very helpful in pointing first to it being a muscle disease, and secondly to identifying the actual subtype. So one very useful set of blood tests, which many of you have probably had, are known as muscle enzymes. and those are CK, also known as CPK, which is an abbreviation for actually creatine phosphokinase. Another enzyme is another muscle enzyme is aldolase, and these two labs are fairly muscle specific. Okay, so if you have a markedly elevated CK and or aldolase, it is almost always a sign of an underlying muscle problem. It doesn't necessarily mean it's myositis. And the flip side of that is in slowly progressive muscle diseases, such as IBM, it's not uncommon actually to have a normal CK. So CK in and of itself is actually not very helpful in diagnosing IBM, and it's certainly not helpful in following IBM. So oftentimes doctors might think after starting a myositis patient on prednisone that since their muscle enzymes have gone from 5,000 down to 500, that they're actually treating the patient. In other forms of myositis, we think that's true. We think it's actually there is a relationship between underlying disease activity and muscle enzymes. However, it's been shown in numerous studies actually that in IBM, there actually is not a relationship between actual disease activity, severity, and CK. Another test which is often done, which is very helpful, is called an EMG, electromyogram. Many of you have probably had this test. The EMG is able to tell us if there are problems in individual muscles, and if so, if it has a physiology consistent with an inflammatory response, meaning the actual recording in individual muscles will tell you whether an individual muscle is affected and whether it looks like there are inflammatory cells in there. Now, you can only really tell if there's inflammation with a muscle biopsy, but an EMG is helpful because it can be suggestive and tell you where a doctor wants to biopsy. Other diagnostic tests are often helpful, and I'm going to talk about a few of those. So, okay, next let me just sort of back up a little bit. So I've given you a broad overview of myositis, and now I'm going to actually focus on inclusion body myositis. So inclusion body myositis, unlike the other forms of myositis, is most often actually present in adults over the age of 50. In other autoimmune diseases, other forms of myositis, it's usually it's more common in younger patients, and it's more common in women. In contrast, in IBM, it's almost 3 times more common in men, and we don't really understand why that is. Now, you'll often hear actually different types of IBM. So you may have heard of sporadic IBM or familial IBM, hereditary IBM. So in most cases, in 95% of the time, an IBM diagnosis is equivalent to actually sporadic IBM or SIBM. Okay, the other forms of IBM are extremely rare. So it's probably 99%. It's sporadic IBM. So it's incredibly rare to have either hereditary or familial IBM. Another distinguishing feature of inclusion body myositis is that it's typically, the onset is very slow. Okay, and that leads to often a very long lag in diagnosis, with an average of about 5 years between onset of symptoms and actually making a diagnosis. And oftentimes patients are told, you're just getting older, you're having difficulty, standing up from a chair, because you're out of shape, you need to exercise more, et cetera. A lot of you have probably heard that. And the reason why is, weakness and slowing down with aging is common, but in IBM, it is clearly a progressive disease. So the onset of muscle weakness is also usually painless. So the pain that is common in IBM is more often from the joints and tendons, and less often from the muscle itself, unlike many other forms of myositis. What actually allows an experienced clinician to actually make a diagnosis of IBM is really based on the pattern of muscles that are actually affected. So it has, again, we don't understand why, but the pattern of muscle weakness is almost always weakness of the finger flexors and weakness of the knee extensors or quadriceps muscles. Other muscles that are often affected are muscles in the lower leg that control your ankle, and weakness often causes foot drop. Weakness of the muscles in the throat and the pharynx, and that can lead to actual difficulty swallowing. And so it's really this sort of characteristic pattern of weakness affecting forearm flexor muscles and knee extensors that is helpful in diagnosis. Another interesting finding is that the weakness in IBM is often very asymmetric. So it's not uncommon to have early on severe weakness on one arm or one leg and almost normal strength in the other. So here's an example of one of my patients who is asked to make a fist in both hands. And as you can see here, he's not able to actually bury his fingers on the right hand. And even though he's doing a pretty good job on the left, he's actually not able to fully make a fist even on the left hand. So it's often this really subtle weakness of your distalmost finger flexors, meaning your joints at the very end of your fingers that is often the earliest sign of IBM. And over time, in more severe IBM, what one can see is actual loss of the muscles in the medial part of the forearm, what's often referred to as scalloping of the forearm or a scooped out forearm. In the actual legs, you can often see quite profound loss of muscle in the thigh. So here's an example where in the quadriceps there is loss of muscle on the medial side and the lateral side, and relative sparing of the muscle that runs right down the middle. And this pattern is common in IBM. So oftentimes we'll get an MRI of the muscles, and the reason MRI is helpful is it can actually tell you in more detail exactly which muscles are affected And that pattern of muscles that are affected is often an indication of a specific muscle disease, whether it's IBM or another muscle disease. So what we look at on MRI are actually two series of images. One is known as T1, where fat is bright and muscle is dark, as you can see here. So here's the right thigh and the left thigh muscle. And then another series of images is known as STIR. And on this series of imaging, anything that is bright is what we call edema, which is often a sign of inflammation. So here's an example of a patient with an acute onset of dermatomyositis. And what you can see is that the muscle itself on T1's signal is pretty normal, right? There's not a whole lot of difference between the MRI here and here. However, once you look on this other series of imaging, what we call STIR, you can see all this bright signal. And all that bright signal there is a sign of inflammation. In contrast, in IBM, what we see is that while your hamstrings are often preserved, so the muscles in the back of the thigh are relatively normal here and here, in the anterior part of the thigh and the quadriceps, there is loss of muscle. It's pretty obvious here if you compare this to this and this, as well as increased signal on both T1, indicating a replacement of the muscle with fatty connective tissue, as well as increased signal on STIR, indicating inflammation. So MRI, we find, is very useful in cases in which an underlying diagnosis is not clear. So if a muscle biopsy has been done, IBM is actually suspected, but the actual pathological features aren't seen. The MRI is helpful in two ways. One, if you see this pattern of muscles affected, it's suggestive of IBM. And secondly, what you can do is use an imaging study, whether it's MRI or CT or ultrasound, and actually find the best muscle to biopsy, so that if a repeat muscle biopsy is done, the odds of it actually being diagnostic are much higher. Okay, so again, on muscle biopsy, this is what we look for. So as you can see here, there is actually invasion of what are otherwise normal appearing muscle cells by actually surrounding T cells within the muscle. So not only are there T cells present in the muscle, but often one can actually see them attacking muscle cells. The other feature that a pathologist will look for to make a diagnosis are what are known as rimmed vacuoles. Rimmed vacuoles are often, but not always, seen in IBM, and are very rarely seen in other forms of myositis. So if the actual diagnosis is in between, say, polymyositis and inclusion body myositis, if one sees the presence of rimmed vacuoles, usually that's very helpful in establishing a diagnosis of inclusion body myositis. Okay, so what are actual inclusion bodies? We've been talking about inclusion bodies this whole time, and I haven't really introduced what that term is. Oftentimes patients will think that it has something to do with their own body. I can assure you that it's not. It has nothing to do with the body itself. It is a pathological term, meaning a term that is seen under the microscope. And really all that means is that under the microscope, if one stains a section of a muscle biopsy with an antibody or other markers in inclusion body myositis, one can see these actual collections or inclusions of what we think are misfolded and aggregated proteins. Okay, so it's simply a pathological term that is descriptive of what is seen under the microscope. Now, in the old days, in the 1950s, when IBM was really first described, electron microscopy was always done, and it was the electron microscopy showing these inclusion bodies that was considered diagnostic of inclusion body myositis. So it's electron microscopes are really high-powered microscopes and are able to see these misfolded aggregated collections of proteins. Nowadays, since electron microscopy is very expensive, very laborious, instead of doing EM, we'll do an antibody stain looking for a number of proteins that are known to misfold in IBM. So if on your muscle biopsy report it talks about aggregates or inclusions of proteins, it may mention something like P62 or TDP43 or tau. So a lot of different proteins are known to form these aggregates in IBM. And this is what we mean when we say inclusion bodies. So it's a descriptive pathological term. Okay, so many of you may be wondering, how certain is my doctor that I actually have IBM? How can he be sure? So if you read on the internet, you'll see there are many proposed actual diagnostic criteria of making a diagnosis of IBM. In 2014, actually Steve Greenberg and I analyzed over 300 patients with IBM and related forms of myositis. And we asked, okay, what features on exam and or muscle biopsy are most predictive, are most definitive of a diagnosis of inclusion body myositis? And what we found is that if a patient has all three of these, we can be essentially 96% certain of IBM as the correct diagnosis. And those are, as I mentioned before, on exam having either finger flexor or knee extension weakness, number one. Number two, a presence of inflammatory cells in the muscle is really all that's meant by endomysial inflammation, so inflammatory cells in the muscle. And number three, actually seeing evidence of the inflammatory cells invading and attacking the muscle, or if we see what are called rim vacuoles. And rim vacuoles are sort of a consequence of the inclusions. Okay? So as you can see from this, as I mentioned earlier, really it's the combination of the exam and the muscle biopsy that leads to a diagnosis. So many of you have probably had an antibody test. So autoantibodies are very helpful in particular in making a diagnosis of other types of myositis, like dermatomyositis and polymyositis. In 2013, actually Ben Larman, who is now at Johns Hopkins, along with Steve Greenberg, identified an autoantibody that was present in about 2/3 of inclusion body myositis patients. And using their test, what they found is that it was about 92% specific, meaning that if the antibody was found, you were about 92% certain that IBM was the correct diagnosis. Now, in subsequent studies from our group and others, many other groups have found that the actual sensitivity is much less. So 76% is about as high as has been found, but in many cases as low as 37%. And what that means is that a negative antibody test is really not helpful. So if you've had this NT5C1A IBM antibody test and it's negative, it actually tells me nothing. It doesn't suggest that it's not IBM. And furthermore, the more that we actually do this test in other patient populations, so in populations with other autoimmune diseases, for example, Sjogren's syndrome, which I talked about earlier, it can be positive even in the absence of any muscle disease. So even if an antibody test is very highly positive, it is not in and of itself diagnostic. So what we've learned is that while an antibody test may be helpful if it's positive in difficult to diagnose cases, it's in most cases, it's really no substitute for a muscle biopsy and a careful exam. Okay, so if it's not IBM, what are other possibilities? So probably the most common muscle disease, which is confused for IBM, is actually polymyositis. What we've learned over the last 20 years is that actually polymyositis is incredibly rare. So around 20 years ago, most patients who were being diagnosed with polymyositis actually probably had inclusion body myositis or another muscle disease. And probably the most important reason why it's really important in making that distinction is in polymyositis, those patients are usually very responsive to immunosuppressive medications like steroids. In contrast, in IBM, usually immunosuppressive medications are not helpful. And then, and based on what I was showing you on the muscle biopsy results, there are other muscle diseases that can show you inclusion bodies and rim vacuoles and some of these, and even inflammation. And the most common actually set of muscle diseases that are misdiagnosed as IBM are inherited muscle diseases or muscular dystrophies. And so while a muscular dystrophy is often considered in patients who have a family history, it's not uncommon for muscular dystrophy to be actually diagnosed in patients without a family history and in older adults. So we're learning more and more that there are actual genetic muscle diseases that can mimic IBM, and they can be found on genetic testing even in the absence of any other family members that are affected. Okay, so now I'm going to switch gears. Let's see how much time I have left. I have about 20 minutes left. So in the next 15 minutes, I'll talk about treatment, and there are other sessions that are really devoted to treatment. So this is really just sort of an overview. How many of you have IBM and your doctor has said, I'm sorry, the diagnosis is IBM and there's nothing we can do, there's no treatment? Okay, yeah, so really unfortunate. Well, it's unfortunate that IBM is so rare that doctors really aren't trained in medical school of all the things we can do in order to help patients. So while it's true there's no cure for IBM, there are many things we as physicians and you as patients can do to help manage the disease. So probably the most important thing that I would like to actually convey to you is, IBM is a lifelong disease, and it's really important that you have a strong support system, and that includes a good physician and a good source of information in terms of ways you can actually help and manage your disease. So what I've listed here are some websites that I think are reliable. So of course our TMA has an excellent website, and there are many others. Actually, Kevin Dooley, who is a physician living with IBM, has made an IBM website known as Cure IBM, which is really good in terms of information on inclusion body myositis, research, clinical trials, etc. He'll often have blogs that will actually talk about IBM. So I think it's real important that you find reliable sources of information. There are a lot of social media sites out there, Facebook, blogs, Patients Like Me, etc. And those can be very helpful, but of course you need to be skeptical and very careful of the information that you receive there. A commonly used website known as UpToDate is often used by general practitioners and family practitioners, and what this website is it has our recommendations on how to manage inclusion body myositis, and it's updated every 6 months or so. And the important thing in terms of management, so what I'm going to talk to you about for the next 15 minutes is that even though there are no proven ways of slowing the actual disease in terms of muscle degeneration, there are definitely things we can do to help actually maintain our quality of life and avoid any complications that might occur. And the actual complications that I worry about the most are problems swallowing and falls. Any of you who are interested in research and clinical trials, there's a great website known as clinicaltrials.gov, and all you need to do is just get on the website and enter in IBM, and every clinical trial that is ongoing in IBM will have a list of different research studies and sites that are actually carrying out that research. And this includes sites really all over the country. Okay, so how many of you have ever been treated with either prednisone or another immunosuppressive treatment, like methotrexate? Okay. And of those who've been treated, how many are still on that treatment? Okay. How many of you are convinced that the actual treatment is or was helpful at some point? Okay. Yeah, so I think that's right. So what we found is that there are probably a minority of patients, maybe 5%, maybe 10%, who at least early in the course of disease actually seem to respond to an immunosuppressive treatment. So whether it's prednisone, IVIG, methotrexate, et cetera. So it makes sense in many cases, at least early in the course of disease, to actually try something like prednisone or methotrexate for a few months and see whether or not that will lead to a significant improvement in weakness. So the reason why it's incredibly hard for actual clinicians to know whether or not any treatment is having an effect is demonstrated here. And that is the actual natural history of IBM is incredibly variable. And what I mean by that, if you follow individual patients over time, so here's day 0 and here's 6 months, what you'll see is actually some patients over the 6-month interval had no change. Actually, some actually improved. So if you look at this patient here, this patient here, this patient, all of these patients without any treatment had some improvement in terms of their muscle strength over the 6-month interval. And many others, of course, had worsening. So it's this slow progression and variable course of disease that actually makes knowing whether any treatment that we give and knowing whether or not that's helpful. So here's a list of essentially every clinical trial that's ever been done in IBM. So you can see IVIG plus prednisone, methotrexate, etanercept. So all of the immunosuppressive drugs that have been tried have failed in clinical trials. And these are some newer ones that are in clinical trials now, which you'll hear more about in future sessions, and we'll also have a question and answer on that. So what I would advise is what I call EBM for IBM, meaning evidence-based medicine for IBM. Okay, so there are conventional treatments that doctors will prescribe, and we think there is evidence for a benefit in some cases. And then there are what we call alternative treatments, which are unproven, and in some cases may have some evidence that actually supports their use, but in most cases really don't have any evidence for efficacy, and in many cases may even be harmful. Okay, so why are there so few clinical trials in IBM? And the main reason really is we don't fully understand what causes IBM. So it's this lack of knowledge of the underlying pathogenesis that is really at the heart of our inability to actually develop drugs. And then secondly, as you probably know, clinical trials are extremely expensive, and that's definitely true for a slowly progressive disease. So if you have to study a drug over 2 or more years in order to know if it's working, the expense in doing that is often prohibitive in terms of doing a well-designed clinical study. So in terms of treatment, though, there are a number of excellent therapies that are proven to work, are proven to be helpful. And many of the sessions at this meeting will actually go into this in more detail. So exercise is probably the actually number one thing you can do to help improve your muscle strength and overall function and quality of life. And that is exercise both in terms of your swallowing muscles, your leg muscles to help you walk, and hand muscles. So in terms of the swallowing problem that is common in IBM, so it's not in everybody. It's maybe in a third to a half of IBM patients will develop problems swallowing. The actual diagnosis of the swallowing dysfunction is made using a video swallow study. And in terms of how we recommend managing the swallowing problems, it falls into 3 sort of categories. If it's mild, meaning occasional choking after eating, or having to change the diet, the most important thing is our exercises that can help improve swallowing, as well as actually training on how to do the Heimlich maneuver for both individual patients and family members. Once it gets in the moderate category, if a video swallow study shows a significant constriction in the pharynx, so it's often this narrowing of the upper esophageal sphincter, which often causes food to go the wrong way when you swallow. And so a common treatment for that is what's known as an esophageal dilation, in which a gastroenterologist is able to go in using endoscopy and dilate that actual constriction. And that's usually very helpful in many patients. And then, of course, if it's more severe, there are more invasive means of treating this, either surgery, what's called a cricopharyngeal myotomy, or a actual feeding tube. Even though that has a very negative connotation, a feeding tube can actually still allow someone to eat normally, but actually get the sufficient amount of calories and nutrition through a feeding tube. So it's an option for actually patients who have severe swallowing problems, and especially if there's weight loss. Now, ankle-foot orthoses. So a common problem is a foot drop from weakness in the ankle dorsiflexion muscles. And what I would say about AFOs, or ankle-foot orthoses, is that there are many, many different kinds, and different kinds work better for different people. There are newer, more expensive orthoses that are coming out all the time. Here's one that I like that essentially combines a ground reaction AFO with a way to stabilize the knee and help prevent any buckling of the knee. And what you'll see are newer devices that are fancy and expensive that sort of combine things like functional electronic stimulation or even robotics to really help ambulation and prevent falls. The evidence is not out yet that these are beneficial. Certainly, there's no evidence that they're any better than sort of traditional AFOs. Now, okay, is that 5 minutes? Okay, perfect. Now, in terms of true evidence-based medicine and exercise, there is really only one good study that is really suggestive exercise is helpful. Okay, but it's what we have, and this study published in 2009 really showed that in IBM patients, regardless of what stage, if you exercise, importantly, you can improve your aerobic capacity, meaning your overall cardiovascular health, which we know is very important in terms of your overall quality of life, your longevity, your mood and mental fitness, and also in terms of it can actually improve your strength of individual muscles. And that is particularly true in muscles that are minimally weak or mildly weak. So in this study, what they showed is after only 7 weeks of exercise, they were able to show a significant improvement in strength in for example, actually arm abduction and hip flexion, which are very important muscles in essentially all activities of daily living. So exercise is probably the number one thing that I would recommend. So there are other sessions on research in IBM and a question and answer session on Saturday for answering your questions that you might have. So I think I'll sort of skip over a lot of these research sides and clinical trials. I'll close with this. There's a lot out there on the internet, a lot of hype. You may have seen this one, MyoX. So it's a myostatin form, and it's actually not at all beneficial. So there's a lot of hype out there. I like this a tweet from actually Justin Bieber saying that it helped him get stronger. Okay, so in summary, what I would say is that if there are treatments that you're interested in trying, if the risk is low and the cost is low, so things like massage, acupuncture, things like that many people find are helpful, that I in general recommend. So if you've tried something, the risk is minimal and you think it helps, there is a lot of power in positive thinking, right? So the placebo effect is a real biological phenomenon. I recommend exercise. I recommend creatine. Creatine kinase, it comes as a powder, and the dose is usually around 3 grams per day. Many patients find that sort of gives them a little bit more energy, and it makes sense because it's what your muscles actually normally use in terms of storing energy. In terms of statin medication, so there's often a fear that if you're on a statin, it might worsen the IBM. We have no evidence that that's the case. In fact, there are studies showing that statins are safe in IBM. So I definitely don't recommend, if you're on a statin, actually discontinuing it. Yeah, and so I'll stop there. I think we're out of time, but I don't have anywhere else to be, so I'm happy to hang out and answer any individual questions you might have. And on Saturday morning, we'll have a 1-hour question and answer session which is dedicated to IBM. So thank you all very much for coming. I hope you enjoy the meeting.